A pleasant day to all. Myself, Dr. P. Rajathi, Associate Professor from the Department of Oral Pathology and Oral Microbiology from Vinayaga Mission Sankaracharya Dental College, is here to give a presentation on cementum. In this presentation, I am going to discuss about parts of tooth, what is cementum, characteristics of cementum, composition of cementum, cementogenesis, types of cementum, structure of cementum, difference between acellular extrinsic fiber cementum and cellular intrinsic fiber cementum, cementodentinal junction, cementoenamel junction, functions of cementum, hypercementosis and clinical considerations. Before going on for cementum, let's have a short recap on the parts of tooth. Here you can see the part of the tooth above the gingiva, you call it as crown. The part of the tooth that is within the gingiva is the root portion. So the outermost covering of the crown is enamel. Inside the enamel is the structure dentin. So the dentin extends from the crown till the tip of the root, whereas enamel extends only in the crown portion of the tooth. Pulp is the vital structure of the tooth that extends from the crown till the root portion of the tooth. The outermost covering of the root is covered by cementum. Outermost covering of the root portion is cementum. The cementum is attached to the alveolar bone by means of the periodontal ligament. Why is any hard tissue is hard? So the hard tissues are enamel, dentin, cementum and bone. How is it different from the soft tissue? Hard tissues have inorganic component, that is the soft tissue has organic component, whereas the hard tissue has inorganic component. That makes the hard tissue hard in consistency. So the main difference between soft and hard tissue is the hydroxyapatite crystals that is present in any hard tissue. So the composition of the inorganic matrix is going to vary between the hard tissues. So here in this tabular column you can see the hard tissues. I have listed out the cells that is going to secrete these hard tissues and where it develops from, that's given in green color. So cell secreting enamel, you call it as ameloblast, cell secreting dentin is odontoblast, the cells that secrete cementum is cementoblast, and the cell which secretes bone is osteoblast. So the organic matrix of each and every hard tissue has been listed out in this tabular column. How is hard tissue formed? Basically, any hard tissue is formed first by formation of an organic matrix. Then there is going to be mineralization of the organic matrix, and then the crystals is going to enlarge in its size and makes it hard. So how is hard tissue formed? First there is going to be formation of an organic matrix. Any cell that is going to secrete the hard tissue is first going to secrete an organic matrix, and then there is going to be deposition of crystals, that is hydroxyapatite crystals. The crystals is going to enlarge in its size and merge with each other, and thus the hard tissue is formed. Here you can see the crystals are deposited and then it is going to enlarge in its size and get mineralized. That's how the hard tissue becomes hard in its consistency. Inorganic matrix is the one that is going to give hard nature for the tissue. Likewise, the organic matrix of each and every hard tissue has a separate name. The organic matrix of enamel, you call it as enamel matrix. The organic matrix of dentin is predentin. The organic matrix of cementum is cementoid, and the organic matrix of bone is osteoid. Coming to our topic, cementum. What is cementum? Cementum is a mineralized dental tissue. That's a hard tissue, right? So this cementum, as I have already told, it is going to cover the anatomic root of the human teeth. So what is anatomic root? The place where the crown is going to meet the root. That is exactly at the cementoenamel junction. Exactly at the cementoenamel junction, that is also called as the cervical line. So the cementum is going to cover the anatomic root of the teeth. It is demonstrated first microscopically in 1835 by two pupils of Perkinch. So the cementum is going to begin at the cervical portion from the cemento-enamel junction to the apex of the tooth, and this cementum is going to provide a medium for the attachment of the collagen fibers, which is nothing but the periodontal ligament fibers that is going to attach the tooth with the hard tissue alveolar bone. That's how the tooth is getting placed within its socket. So the cementum, you can remember, it's a cementing substance. It's going to cement the tooth to the bone. So it's a connective tissue, and this is going to provide attachment for the collagen fibers. So this is going to bind the tooth to the surrounding structures, and this is a specialized connective tissue similar to bone. But what is the difference between bone and cementum? In case of bone, it has vascularity, but in case of cementum, it is avascular and doesn't have any innervation. It's non-innervated. Thickness of the cementum is not same throughout the root portion of the teeth. It is going to be thinnest, that is at around 20 to 50 micrometer in the cemento-enamel junction, that is at the cervical third, whereas it is going to be thickest at the apex, 150 to 200 micrometer. Coming to physical properties, the hardness of the cementum is going to be less than that of the dentin. This you can appreciate in the tabular column, as we have discussed already. The inorganic matrix of the cementum is going to be less than that of the dentin. The inorganic component of dentin is 65%, whereas cementum is 45 to 50%. So the hardness of cementum is less than that of the dentin. Coming to color of cementum, it is going to have a light yellow in color, but it is going to be lighter than that of the dentin. Compared to enamel, enamel is going to have a luster. That can be appreciated in this picture. That's very shiny. Enamel is very shiny. You can see that luster in the enamel portion of the tooth, whereas cementum lacks this luster. That's how you can distinguish the crown from the root portion of the tooth. Next, coming to chemical composition of cementum. The inorganic component of cementum is going to be 45 to 50%. That is, it is composed of calcium and phosphate in the form of hydroxyapatite crystals. In case of cementum, this hard tissue is the one that is going to have the highest fluoride content of all the mineralized tissues. So also it contains many trace elements. Among these trace elements, fluoride is going to be most in case of cementum. Next, coming to organic component. It comprises of 50 to 55%. The remaining amount is going to be water. What makes up this organic component? The main component of organic matrix is type 1 collagen. It also contains non-collagenous proteins, proteoglycans, growth factors. Non-collagenous proteins. The role of non-collagenous proteins is it's going to play a major role in matrix deposition, initiation and control of mineralization and matrix remodeling. Coming to the organic component, I have already said type 1 collagen is the major collagen that is present in the cementum. There are other types, that is type 3, 5, 6 and 12 is also present. Non-collagenous proteins that is present in cementum are bone siloprotein, osteopontin, cementum derived attachment protein, which is very unique for cementum. That is, cementum derived attachment protein is present in cementum. In no other hard tissue it is present. Next, coming to growth factors, transforming growth factor beta, cementum derived growth factor, fibroblast growth factor, epidermal growth factor, platelet derived growth factor, insulin like growth factor, all these growth factors are present within the cementum. Next, proteoglycans. Proteoglycans present in cementum are chondroitin sulfate, heparin sulfate, keratin sulfate, hyaluronate, biglycan, osteoaderin. All these proteoglycans are present at similar to bone. Next, coming to cementogenesis. You would have studied in development of teeth that how the tooth is being formed. Let's have a short recap on how the tooth is formed. The ectodermal structure that is going to line the oral cavity is going to proliferate and it is going to assume the shape of bud. So from bud, it is going to go through different stages: bud, cap, early bill and advanced bill. So what makes up the tooth germ? So the ectodermal structure is going to proliferate. The surrounding connective tissue cells is going to condense next to the enamel organ. So surrounding this enamel organ, you have dental papilla. Next to the dental papilla, there is a less condensed ectomesenchymal cells, that is the dental sac. So the enamel organ, dental papilla and dental sac together constitutes the tooth germ. So the structures that is formed from enamel organ, dental papilla and dental sac is listed out here. From enamel organ, enamel is formed. Dental papilla gives rise to dentin and pulp. Dental sac gives rise to cementum, alveolar bone and periodontal ligament. So you can see in this picture the varying stages how from bud it is going to, the enamel organ from the bud shape it is going to have a cap shape. So in the cap shape you can see the dental papilla is located within the cap of the enamel organ. The dental sac is going to surround the enamel organ and the dental papilla. From cap stage, it is going to proceed to early bell stage. What happens in early bell stage? There is going to be differentiation of the cells that is going to happen, and it is going to result in formation of hard tissues. So once there is going to be formation of hard tissue, it means enamel organ has reached the advanced bell stage. The dental papilla cells next to the enamel organ is going to differentiate into odontoblast cells, and in presence of odontoblast cells, the enamel organ ameloblast cells get differentiated. The inner enamel epithelium cells of the ameloblast will get differentiated into ameloblast. Under the influence of the ameloblast, the odontoblast is going to secrete dentin. The first hard tissue that is formed is going to be dentin. As soon as a layer of dentin has been formed, the ameloblast cells is going to secrete enamel. So the dentin is produced and the odontoblast is going to move inside, and ameloblast is going to secrete enamel and it is going to move outside. So the deposition of hard tissue of the tooth is going to begin at the cusp tip. From cusp tip, as it reaches the cervical portion, so you can see here in this picture odontoblast within the dental papilla lining. Here all these are odontoblast cells, and the enamel organ I have drawn. Here you can see the ameloblast cells. Odontoblast is going to secrete dentin, ameloblast is going to secrete enamel. So once this formation of dentin and enamel is going to reach the cervical portion, that is at the CEJ, that as soon as it reaches the cervical region, there is going to be some root formation is going to begin. So how is this root formation is going to happen? Here you can see the enamel organ, the inner enamel epithelium, that is ameloblast cells. Outside the enamel organ, it is lined by cuboidal cells, that is nothing but the outer enamel epithelium. So the point where the outer and inner enamel epithelium meet, we call it as cervical loop. So from the cervical loop, only the inner and outer enamel epithelium is going to proliferate and move apically, that is towards the tip. So as it proliferates and moves, so only a two layer of outer and inner enamel epithelium is going to proliferate. See, the inner enamel epithelium and the outer enamel epithelium alone is going to proliferate, and this structure you call it as Hertwig's epithelial root sheath. So inside the Hertwig's epithelial root sheath, there is going to be dental papilla. Outside the Hertwig's epithelial root sheath, it is going to be covered by the dental sac. Remember, the outside enamel organ, there is going to be dental sac. Inside the enamel organ is going to be dental papilla. Along with the proliferation of the Hertwig's epithelial root sheath, the dental papilla and the dental sac is also going to proliferate, condense and come along with this Hertwig's epithelial root sheath. So during this proliferation, the dental papilla cells within the Hertwig's epithelial root sheath is going to get differentiated into odontoblast cells. The cells that is going to be next to the Hertwig's epithelial root sheath is going to get differentiated and form odontoblast cells. After differentiation of odontoblast cells, the odontoblast cells is going to secrete dentin. As soon as a layer of dentin has been formed, the Hertwig's epithelial root sheath is going to disintegrate. So once this Hertwig's epithelial root sheath get disintegrated, what is outside the Hertwig's epithelial root sheath? Outside the Hertwig's epithelial root sheath, dental follicle cells are there. So the dental follicle cells, remember, those cells are going to secrete cementum, periodontal ligament and alveolar bone portion. So the dental follicle cells after disintegration of the Hertwig's epithelial root sheath is going to get differentiated into cementoblast and fibroblast. The cementoblast and fibroblast, they will come and contact the dentin and then they are going to secrete cementum and periodontal ligament fibers. So the cementoblast, I have given yellow color for cementoblast cells and pink color spindle shaped cells are fibroblast cells. As soon as the Hertwig's epithelial root sheath HYRS breaks, the cementoblast will come into contact and the fibroblast cells will come into contact with the dentin, root portion of the dentin. Then on left side I have explained about formation of extrinsic fibers by the fibroblast. We will be talking in detail about extrinsic and intrinsic fibers. Here just remember fibroblast cells of the HYRS is going to secrete extrinsic fibers. So here you can see as soon as the fibroblast cells contact the dentin portion, it is going to secrete collagen fibers. Fibroblast cells will secrete periodontal ligament fibers. So the periodontal ligament fibers are nothing but collagen fibers. So within the cementum, this is also going to be extrinsic fibers is going to be present. Next, coming to intrinsic fibers, the cementoblast cells which is in contact with the dentin is going to secrete cementum and the fibers that is going to be secreted by the cementoblast is intrinsic fiber cementum. Okay. So here if you can see the alignment of the fibers, the fibroblast cells that is going to secrete the extrinsic fibers, it is perpendicular to the surface of the cementum. Whereas the cementoblast cells that is going to secrete intrinsic fibers is arranged parallel to the surface of the cementum. So we will be talking in detail about the intrinsic and extrinsic fibers in the further slide and the type of cementum. So coming to types of cementum, based on the presence or absence of cementocyte, it is cellular cementum. If cementocyte is present, it is cellular cementum. If cementocytes are absent, you call it as acellular cementum. What are cementocytes? Cementoblast cells, while secreting cementum, if they get entrapped within the cementum structure, that you call it as cementocytes. So if cementocyte cell is present within the cementum, you call it as cellular cementum. If cementocyte cell is absent, then it is called as acellular cementum. Based on the presence or absence of fibers, if fibers are present, it is fibrillar cementum. If fibers are absent, then you call it as afibrillar cementum. Fibrillar cementum is again further classified into intrinsic fiber cementum and extrinsic fiber cementum. The types of cementum are acellular extrinsic fiber cementum, which is nothing but the primary cementum, cellular intrinsic fiber cementum or secondary cementum, acellular afibrillar cementum, acellular intrinsic fiber cementum, cellular mixed fiber cementum, acellular mixed fiber cementum and cellular mixed stratified cementum. Here you can see alternating layers of acellular extrinsic fiber cementum and cellular intrinsic fiber cementum. So mixed fibers will contain both intrinsic and extrinsic fibers. Next, coming to structure of cementum. The structure of cementum, I have already said the organic matrix of cementum you call it as cementoid. Cementoid is nothing but the uncalcified matrix or the organic matrix of cementum. The growth of cementum is going to be a rhythmic process. Once a new layer of cementum is being formed, the old layer, that is once a layer has been formed, it gets calcified. and then there is going to be another layer, right? So you can see a very thin layer of cementoid usually on the cemental surface in the root portion of the tooth. Cementoid tissue is not absorbed in acellular extrinsic fiber cementum. Acellular extrinsic fiber cementum is present in cervical tooth of the root. So next is intrinsic fibers. I have already said intrinsic fibers are produced by cementoblast of the dental follicle cells, and these intrinsic fibers is going to be arranged as smaller bundles with 1 to 2 micrometer in diameter, and they are oriented parallel to the surface of the cementum. Whereas extrinsic fibers are produced by fibroblast cells, that is periodontal ligament fibroblast of the Hertwig's epithelial root sheath is going to secrete the extrinsic fibers, and these bundles are going to be larger in size compared to the intrinsic fibers, and the size of the bundle is going to be 5 to 7 micrometer, and the fibers are going to be oriented perpendicular to the surface of the cementum. These extrinsic fibers are also called as Sharpie's fibers. The collagen fibers that are embedded into the cementum on one side and embedded into the bone on the other side, you call it as Sharpie's fibers. So what are Sharpie's fibers? They are nothing but the periodontal ligament fibers that is embedded within the cementum and the bone. So the extrinsic fibers of the cementum are derived from the periodontal ligament fibroblast, and it is going to be oriented perpendicular to the surface of the cementum. Next, cementocytes. Cementoblast cells during formation of cementum, I already said, it's going to get entrapped at few regions, and these cells you call it as cementocytes, and these cells are similar to osteocytes. It is arranged within the lacunae, and you can see canaliculi or radiating process within the canaliculi, and these processes in case of cementocyte is going to be towards the periodontal ligament. So the process will be mostly directed towards the periodontal ligament surface of the cementum, and these processes can be best viewed in mineralized ground sections but not in decalcified sections. What is the difference between cementocyte and osteocyte? Here in case of cementocyte, the lacunae will be ovoid or tubular, whereas in case of osteocyte it is oval, and the canaliculi will be less complicated and sparse, whereas in case of osteocyte the canaliculi will be more dense and complex. And in case of cementocyte, you can see majority of the canaliculi will be oriented toward the periodontal ligament surface. Whereas in case of bone, that is in case of osteocyte, the canaliculi will be radiating. And on immunocytochemistry, the cementocyte will be positive for fibromodulin and lumican. It's nothing but keratin sulfate. Whereas it is going to be negative for fibromodulin and lumican in case of osteocyte. Next, coming to acellular extrinsic fiber cementum. This is nothing but the primary cementum or the first formed cementum, and this cementum extends from the cervical margin to apical 1/3 of the root. This is the only type of cementum that is present in single rooted tooth. The collagen fibrils that is going to form a bulk portion of the organic. In case of acellular cementum, collagen fibrils form a major portion of the cementum. A small amount is formed by the non-collagenous protein. Also, the extrinsic fibers that is going to make up this AEFC, that is acellular extrinsic fiber cementum, is going to be oriented perpendicular to the surface of the root or the cementum, and these extrinsic fibers you call it as Sharpie's fibers. And these extrinsic fibers are mineralized except in their inner cores, and the cementum, if the cementum is going to be thinner if the cementum is going to be thin, the Sharpie's fibers is going to pass the entire structure of the cementum, and this process, acellular extrinsic fiber cementum, is formed slowly. Because it is formed slowly, there is going to be a resting period during formation of cementum. So because it is formed slowly, the intrinsic lines of cementum is going to be closer to each other, and unmineralized matrix or cementoid tissue will not be seen in case of acellular extrinsic fiber cementum. The main function of this acellular extrinsic fiber cementum is anchorage. Coming to cellular cementum. Cellular cementum, that cellular intrinsic fiber cementum is a secondary cementum which is formed later to acellular extrinsic fiber cementum, and this cellular intrinsic fiber cementum is present in apical 1/3 of the root and also in multi-rooted tooth. So this cellular cementum is of two types, that is cellular mixed fiber cementum and cellular intrinsic fiber cementum. So this cellular mixed fiber cementum occupies the apical and the interradicular region. The cellular intrinsic fiber cementum is present in the middle and the apical third. Cellular cementum is formed at a faster rate. Because it is formed at a faster rate, there is going to be entrapment of cementoblast cells within the cementum, and those cells only we call it as cementocytes. Not only cementoblasts get entrapped, a large amount of cementum is going to be formed. So the resting line is going to be wider apart, that is the incremental lines of Salter is placed wider. Main function of cellular cementum is adaptation and repair of cementum. So what are all the difference between acellular extrinsic fiber cementum and cellular intrinsic fiber cementum? I have listed out as a tabular column. Acellular extrinsic fiber cementum is present in the cervical to the apical 1/3. So in the apical 1/3, cellular intrinsic fiber cementum is present, and also it's seen in the interradicular between the roots. You can see cellular intrinsic fiber cementum, and acellular extrinsic fiber cementum is the primary cementum or first form cementum, and secondary cementum or formed later to acellular extrinsic fiber cementum. Here if you can see, in acellular extrinsic fiber cementum few structures are absent, but it's going to be present in cellular intrinsic fiber cementum. Non-collagenous proteins, cementoid tissue, growth factors, proteoglycans all will be present in case of cellular intrinsic fiber cementum, whereas in case of acellular extrinsic fiber cementum all these are absent. Acellular extrinsic fiber cementum contains extrinsic fibers produced by fibroblasts, whereas cellular intrinsic fiber cementum contains intrinsic fibers produced by cementoblast cells. Here you can see the formation and the incremental lines and about the cementocyte. In case of acellular extrinsic fiber cementum, it's going to be formed slowly, and because it is formed slowly, the resting lines or the incremental lines are closer to each other. Whereas in case of cellular intrinsic fiber cementum, it is formed at a faster rate, and during its formation you can see entrapment of the cementoblast cells, which is nothing but after it get entrapped you call it as cementocytes. And if you can see the resting lines in case of acellular extrinsic fiber cementum, it is close. Here you can see it as it's further, it's wider apart. So the extrinsic fibers of the acellular extrinsic fiber cementum is arranged perpendicular to the cementum, whereas in case of cellular intrinsic fiber cementum, it is arranged parallel to the surface of the cementum. So function for acellular extrinsic fiber cementum is anchorage, whereas in case of cellular intrinsic fiber cementum it is adaptation and repair. Cementoblast of acellular extrinsic fiber cementum do not express parathormone receptor, whereas cellular intrinsic fiber cementum fibroblast will express parathormone receptor. Next, coming to cementodentinal junction. What is cementodentinal junction? The junction between the cementum, that is the outermost covering of the root, and within the cementum you have dentin, isn't it? Radicular dentin. So the junction between the cementum and dentin, you call it as cementodentinal junction. So this junction is going to be smooth in case of permanent tooth, whereas it's going to be scalloped in case of deciduous tooth, and the attachment between the cementum and dentin is going to be firm. You can see a clearly visible interface in case of a decalcified section, and the cementum will stain more intensely than dentin. Why? The organic matrix is going to be more in case of cementum compared to dentin. Inorganic matrix is less, but organic matrix is more in case of cementum. So with electron microscope, the cementodentinal junction is not as distinct as you see it in light microscope. The cementum is going to be more electron dense than the dentin. The collagen fibers of dentin is going to be arranged haphazardly, whereas cementum, you can appreciate it very clearly, the extrinsic fibers that is going to pierce through the cementum. So that is arranged more distinctly. The cemental fibers is going to intermingle with the dentinal fibers at the cementodentinal junction. That is going to be more in the cellular cementum than an acellular cementum. Intermediate cementum layer. Sometimes the dentin is separated from the cementum by a zone known as intermediate cementum layer. This layer is a structureless layer. It doesn't comprise, it does not exhibit the characteristics of either dentin or cementum. This structureless layer is also called as hyaline layer of Hopewell-Smith, and it is predominantly seen in the apical two-third of the roots of molars and premolars. So this intermediate cementum layer is rarely observed in incisors or deciduous tooth. There was earlier belief that this layer represents areas where the cells of HERS become trapped in rapidly deposited dentin or cementum matrix. Next, coming to cementoenamel junction. What is cementoenamel junction? I have already said crown and root portion. The crown portion is covered by enamel, the root portion of the tooth is covered by cementum. The exact point where the enamel and cementum meet, you call it as cementoenamel junction. The relation between the cementum and enamel is going to vary between individuals. So sometimes it's going to meet at a sharp point, that you call it as meet junction or sharp junction. Sometimes there is going to be an overlap of cementum over the enamel. So cementum, instead of being present only in the root portion, sometimes it might extend to the crown portion over the enamel. That you call it as overlap junction. Sometimes there might be a gap between the cementum and the enamel portion. So the dentin of the root will get exposed. That you call it as gap junction. If the cementum overlaps the cervical end of enamel, you call it as overlap junction. That's seen in around 60% of cases. Cementum, if it is going to meet the cervical end of enamel, it's called as sharp junction, seen in 30% of humans. And if there is going to be a gap between the cementum and the cervical end of enamel, you call it as gap junction. It's present in around 10% of humans. Why is there going to be a gap? If the Hertwig's epithelial root sheath doesn't get detached, if there is going to be a delay in detachment or disintegration of the Hertwig's epithelial root sheath, so there is not going to be formation of dental follicle cells differentiation, and it will not come in contact with dentin, hence cementum is not being produced. That's why there is going to be a gap junction. Why do you get an overlap junction? See, after formation of enamel, you all know that the enamel organ is the structure that is going to protect the tooth till it erupts into the oral cavity. So the enamel organ is going to reduce in its size and make up the reduced enamel epithelium, which is 2 to 3 layer of stratified squamous cells. So this reduced enamel epithelium is going to protect the protect the crown portion of the tooth till it erupts into the oral cavity. During its eruption into the oral cavity, it's going to merge with the gingiva and form that endogingival junction. So, if the reduced enamel epithelium get detached at the cervical region, the dental follicle cells might come and contact the enamel portion. So, the dental follicle cells will get differentiated into cementum and it's going to produce cementum. That is how the overlap junction is being formed. Here it is going to form a afibrillar cement. Coming to functions of cementum. Cementum is going to provide anchorage to the tooth. It is going to help in adaptation of the tooth for the occlusal or the masticatory forces, and it is going to help in repair of the tooth. So, these are the functions of cementum. To discuss about the anchorage, cementum is going to provide a medium, we have already discussed that. So, it is going to provide a medium for the attachment of the collagen fibers. If there is going to be absence of cementum, then there is going to be only dentin, right. So, in case of absence of cementum, the periodontal ligament fibers or the collagen fibers will not get incorporated into the dentin. So, only if a layer of cementum is present, the periodontal ligament fibers or the collagen fibers will get incorporated, and thus it is going to help in anchorage. If it is absent, then you cannot expect anchorage or support of the tooth with the alveolar bone or through the periodontal ligament fibers. Next, coming to adaptation. Cementum is going to help in adaptation to the occlusal or the masticatory forces. How? If for the forces, for the wear on the occlusal surface, there is going to be deposition of cementum in the apical region to compensate for the wear on the occlusal surface of the tooth. Usually cementum is not resorbed under normal conditions. As a most superficial layer of cementum is going to age, there is going to be new deposition of cementum around this aged cementum. Coming to repair of cementum. Cementum is going to help in repairing the root surface. In case of any damage to the root, that is fracture or resorption, it can be repaired by formation of new cementum. The cementum formed during repair is going to resemble cellular cementum. That is, it's going to be formed faster, and there is going to be larger amount of cementoid tissue. Cementocytes is going to be present, and the apatite crystals that is present within the cellular cementum is going to be smaller in its size. If repair takes place slowly, then the cementum formed is going to resemble the primary cementum. Coming to hypercementosis. What is hypercementosis? It is nothing but abnormal thickening of cementum in the root portion of the tooth. In the apical portion of the tooth, you see abnormal thickening of cementum, and this is also called as cemental hyperplasia. This hypercementosis can be either diffuse or circumscribed. It may affect all the teeth in the dentition, or it can be confined to a single tooth, or it may even affect only part of the tooth. Sometimes you can see it as a localized hypertrophy or a prong-like projections, that is extension towards the periodontal ligament surface. So, why this is going to occur? This might result because of that area might be exposed to stress. In that case, it needs to provide more anchorage. So, for that the cementum is going to be extended like a spur-like projections, and thus the surface area is going to increase and it is going to have a firmer anchorage. Sometimes there might be presence of enamel drops or the epithelial rest, Hertwig's epithelial root sheath during its formation. After getting detached, few remnants might be present within the periodontal ligament. So, close to the cementum surface. There it might act as a nidus. There might be calcification that might occur on the Hertwig's epithelial root sheath, and this might result in a localized hypercementosis. So, that is one possible reason, and there might be some knob-like extensions in case of this, that you call it as excementosis. Sometimes there might be Hertwig's epithelial root sheath that might get entrapped within the furcation region. There might be enamel drop that is going to get calcified and it might result in hypercementosis. Hypercementosis may be seen extensively in tooth with chronic periapical inflammation. Sometimes you can see excessive deposition surrounding the root like a cuff. Hypercementosis also can be seen in surrounding the non-functioning teeth, or it may be localized in small areas. The cementum is usually thicker around the apex of all teeth in case of furcation of multi-rooted tooth, embedded and a newly erupted tooth. Irregular overgrowth of cementum with spike-like extensions and calcifications of Sharpie's fibers are accompanied by numerous cementicles as a sequelae to injuries to the cementum. That you call it as cementicles. Coming to clinical considerations. Cementum is more resistant to resorption than bone. In orthodontic tooth movement, cementum resorption is very minimal or absent, but bone will resorb. Because of that only, there is a possibility of the tooth to migrate, or the orthodontic tooth movement occurs. Why is this difference in resorption? So, the difference in resistance to the stress that's been exerted on the tooth and the bone. So, that is, the bone is richly vascular, whereas cementum is avascular tissue. The stress being transferred to both in equal amount, but the degenerative process is more in case of bone, whereas in case of cementum, it is the cementum, as any other avascular tissue, is going to have a slow metabolism and it is not being damaged by the pressure exerted by the orthodontic tooth movement. So, that is how the bone is getting resolved, cementum is not getting resolved, and the possibility of the tooth being migrated. Resorption will be seen after trauma or if there is going to be an excessive occlusal force. Severe cases of resorption may continue to dentin. So, if there is going to be resorption, what is going to happen? It is going to be followed by repair either by formation of acellular cementum, cellular cementum, or alternate formation of acellular and cellular cementum. Repair is of two types: anatomic repair, functional repair. In case of anatomic repair, the cementum is going to maintain the outline of the root. That is, the exact amount that's been resolved is being formed and the anatomy is maintained. So, you call that as anatomic repair. So, the outline of the root surface is re-established during the repair process. Whereas, in case of functional repair, a cementum that is formed is going to be very minimal in amount, that is, thin cementum is formed, but how is the anchorage is being established? Here, instead of the root establishing its outline, the alveolar bone is going to be produced more and the periodontal ligament width is going to be maintained. The outer portion of the cementum and the alveolar bone, you call it as periodontal ligament space, where the periodontal ligament fibers is going to be present. So, when there is going to be resorption of the root, and if the cementum is not going to be formed to maintain its outline, the alveolar bone is going to be formed and the space is maintained. Sometimes in case of severe blow, fragments of cementum may be detaching from dentin, that you call it as cemental tears. Transverse fracture of root heals by formation of new cementum. Hypercementosis may occur secondary to chronic periapical inflammation or extensive occlusal stress. In case of excementosis, that is when there is going to be a knob-like extension of the cementum, extraction is going to be difficult. There you have to remove the bone to extract the tooth in case of excementosis present within the tooth. small fragments of root sometimes may be left within the jawbone, but it will not cause any disturbances. Plaque in the periodontal pocket, plaque present in the periodontal ligament is going to alter the nature of the cementum. So, the pathologically exposed cementum is going to be hypermineralized with incorporation of calcium, phosphorus and fluorine from the oral environment. This altered exposed cementum will interfere in healing process during repair, that is during any periodontal therapy. So, during periodontal therapy, you have to remove the altered cemental surface. You have to remove it for periodontal regeneration to occur. Commercially available enamel matrix proteins were coated on the cleaned and planed root surfaces to help in new cementum deposition and regeneration of the periodontal ligament. And the newly formed cementum will be cellular and it has less fibers per unit area, and its bonding with existing cementum will be weak. In case of a disease, that is a Paget's disease or osteitis deformans, there might be an excessive amount of secondary cementum on the root portion of the tooth, that is apical portion of the tooth. In that case, there is going to be disappearance of lamina dura. So, lamina dura is nothing but next to the periodontal ligament space, there is going to be a thickened bone that you call it as, or radio-opaque line that you call it as lamina dura. So, when there is going to be disappearance of lamina dura and a generalized hypercementosis, there might be a possibility of Paget's disease in those individuals. If there is going to be a total absence of cementum, then you have to suspect hypophosphatasia. In case of type 2 diabetic patients, the cementum is going to be thicker. So, you have to know about the structure of cementum, the variations that is going to occur in cementum to diagnose few diseases and also for the healing process. Thank you for listening to this presentation. Thank you all.